Hi, everyone, and welcome to our latest episode of our What's Up Doc series, where we feature a doctor answering your questions. It's not often that you get to talk to a doctor outside of your regular consult. You might get to see your doctor once, maybe twice a year, but you have a lot more questions than you can fit into a 15-minute consult. So we have doctors from around the world that have generously donated and continue to donate their time, including Dr. Edel Mendoza, who is an interventional radiologist from American Endovascular. And we'll get to, I'm not sure if he's in the New Jersey office or if he's in New York. So we'll get to that in a moment. But we have this every single week, every Tuesday. So make sure you do join in, because we have doctors that come in from around the world to answer your questions as best they can. But always remember, the advice and views offered by the speakers, especially our doctors, are that of the doctors, the clinicians, as well as myself. Make sure that you do not take or act on any advice or information offered in this series without the explicit consent of your own healthcare team that knows your situation best. That's very important. So without further ado, I want to introduce Dr. Edel Mendoza. Thank you so much for being here today.
Sure, no problem.
We really appreciate it. You're new to our organization, so it'll be fun to hear your experience in answering all of these questions today. We have a great live studio audience here who can't wait to ask you the questions. But I want to start out, with being an interventional radiologist, there are so many different areas you could have focused on. Why PAD?
Well, it was in training where we're kind of exposed to multiple areas of interventional radiology. There's multiple fields in the specialty itself. And I was just drawn to PAD, once I was taking care of those patients, just because specifically in kind of patients with vascular disease, you really see the kind of payoff of your hard work. A lot of procedures that we do, we see immediate benefit. Patients feel better, they get better either the same day, the next day. It's minimally invasive procedures where it's not open surgery, and really kind of futuristic in a sense. And a lot of the technology is really growing in the field to allow us to do things that we were not able to do before. And a great feeling taking care of those patients and seeing and getting good outcomes from the procedures that we do on them.
So you're a young guy. So many doctors don't learn advanced methods for treating PAD. Why are you committed? I mean, you're working with some of the most advanced doctors in the industry that are even leading with their own innovative, cutting edge ideas and techniques to go the extra mile and exhaust all efforts and go beyond even what is available today. They create their own ways to save limbs.
Yeah.
Why are you committed to this?
Kind of, echoing what I said earlier, a lot of the procedures that we do, then the main goal is to really improve the quality of life of patients and prevent any major amputation. And really, kind of seeing the success rates of those procedures really kind of makes the taking care of the patient kind of really gratifying. This is kind of a lifelong disease, unfortunately, and you kind of get that kind of long-term care that you have with the patient rather than kind of a one and done kind of deal in certain other specialties and in certain other kind of fields as well. But really kind of, these are very hard procedures. We're dealing with very tiny vessels, kind of the size of a spaghetti noodle even, and opening up kind of those blockages can be very challenging. But really, once we're able to open up the blood flow and really get nice either wound healing or preventing an amputation is just really gratifying and kind of feeling that your hard work's really paying off. Compared to other kind of diseases that we treat with, it's just kind of taking care of high blood pressure or diabetes and things like that, where it's a slow process over a couple of months to years. we really just see that kind of instant gratification and satisfaction that we take in managing our patients.
So here's a good one for you. I want you to share a case with a big lesson for you and others. I want you to describe the patient, the frustration with the case, and the lesson you learned and others can learn from it. It could be a success, it could be a failure, it could include a little bit of ingenuity. What do you think?
Um, yeah, I mean, there's a couple that come to mind, but and they all kind of are along the same story. But we often see a lot of patients where they've been having issues for a while and kind of seen multiple doctors, their primary care doctor, orthopedic specialist, a podiatrist, a rheumatologist, and things like that, where they haven't really been able to find an answer. And then they kind of see us and we're able to diagnose and treat them with their vascular diseases. And I had one patient who his arteries were completely blocked basically from the middle of his abdomen all the way down to his knees in both legs. And he was not able to walk, and he had severe pain and a wound on his right leg. And it's been going on for about, I would say, 8 to 10 years. And he's been following with doctors. No one really kind of gave him any direction. They've just been kind of treating his symptoms. But I don't know how it went on for that long, but it wasn't until he had a consultation with us that we were able to kind of find out that he did have complete blockages in both legs, and we were able to open up those blockages and place stents in a kind of a same day procedure. It was a long procedure. It took about 4 to 6 hours, but we were able to do everything in one sitting. Restore the blood flow into his legs, and his leg pain was completely resolved. At his 1 month follow-up, he was able to walk. He was able to basically live his life back to normal. And he was just so relieved and so happy that he was able to kind of get that relief from his pain that he's been having. He's been on kind of narcotics for about 7 years. You just think of just the problems with that alone. And they've just been kind of treating his pain and not really addressing the root problem. And it really is just that kind of feeling of giving someone their life back in a sense, and really preventing, at that point, he was, I would say, at kind of in the scenario where he possibly could lose both of his legs if things were to get worse. So to really kind of prevent that. And really, I think I just saw him recently, and that was about 8 months ago. And he's doing great. So I would say that's definitely a nice success story. And especially, I think he saw 4 or 5 specialists at that point that were not really able to fully treat him.
So the lesson learned?
I would say definitely, I think vascular disease and kind of vascular awareness is not well recognized, I would say. I think the main reason is because there's a lot of overlap between problems in the legs. There's people, if a vascular person will look for vascular issues, an orthopedic doctor will look for bone or muscle issues, and things like that. And a lot of them can overlap, where you have nerve issues and things like that. But I would say definitely um, it it's not something that one person can take care of on their own. This is kind of a team effort with a bunch of other doctors, and I think it's not something that I think anyone should go at alone. So it's something that I think we need everyone's assessment on to really get to the root of the problem.
And I have 2 more before we open it up for everyone can get their questions ready for you. So be prepared. The firing
Sure.
squad is it's getting geared up. They're arming their weapons right now.
Yeah.
So you kind of touched on this, but we need you to put this in a nutshell. It's part of a series that we're doing called Journey to Diagnosis. So in a nutshell, I want you to share a case that just had you scratching your head about how in the world this patient was not diagnosed sooner and what you wished would have happened differently with that patient, or share a story of a patient whom you couldn't believe had a different procedure, such as a spinal fusion, which didn't alleviate their symptoms, but should have been diagnosed and treated for PAD instead?
Hmm. Um, so the ones that come to mind, I would say what would be the most common would be kind of chronic venous disease, or kind of vein problems, specifically dealing with chronic DVT. I think in the medical community, even kind of just about maybe 5, 10 years ago, kind of the common thought was that there's nothing you can do for a chronic DVT. There's it's just really compression socks and blood thinners are the main treatment. But we know that with chronic DVT, you can get something called post-thrombotic syndrome, which is kind of the lingering effects, and kind of the damage to the blood vessels, to the veins, from that initial blood clot. And there are procedures that we can do where we open up these veins. These veins are often scarred down, kind of similar to PAD, where you kind of have narrowing of the arteries, but here it's kind of on the vein side. And it can lead to really a lot of chronic issues for patients, kind of chronic leg swelling, chronic leg pain. They can develop wounds on their calves and get some darkening of the skin and lead to a lot of disability and decreased quality of life. That we often see that patients with chronic DVT that we end up seeing, they say, I've been following up with my doctor for the last 5, 10 years, and they just said there's nothing to do about it, and that was really kind of that. And it really isn't until we see them that we're able to offer them some treatment options, that they are often interested in, just due to their kind of chronic leg pain and swelling. And that's really been a shift because of the technology that's been advanced ever since, I would say, since the early 90s and early 2000s, in treating chronic DVT. A lot of these kind of equipment that we have, we didn't have before. And it's just that kind of medical knowledge lag where we have this new technology, and it's time to educate kind of everyone else who's kind of been used to the old ways, and kind of getting them on board. So it's really done by more kind of, treating patients, patient by patient, as well as community outreach and reaching out to the doctor saying, hey, we're available, we're able to do this. We're able to do this procedure and take care of these kind of subset of patients, because we definitely know that they're around, and it's just oftentimes they've told that there's nothing we can do about it, and kind of are kind of forgotten, for over years. And so I think that's kind of one area that we really made some big steps in now that we were able to take care of those patients.
That was a good one. I haven't had that one yet. And then one more, and then we'll open it up, I promise. This is another deep one. It's going to make you think. I want you to share 6 minutes that mattered in your career. It has to be a defining moment, a catalyst for change, a spark that led you in a specific direction. It could be a conversation you
Hello?
had with someone, a scene in a movie, a show, a documentary. It could even be a moment where you witness something that's eye-opening.
I'm sorry, can you just repeat that? You were cutting in and out during the question.
Sure. I want you to share 6 minutes that mattered in your career. It has to be a defining moment, a catalyst for change in your life, in your career. It could be a spark that led you to in a specific direction. It could have been a scene in a movie or a show or a documentary. It could have been a moment where you witnessed something eye-opening, and it could be as simple as a conversation that you had with one person.
You said a life-defining moment that kind of pushed me to do interventional radiology, or do medicine in general, or?
Something, or it could have been that moment where you, a defining moment for a specific technique, or, something that led you to practice differently.
Okay, okay. It's a good question. Let me think about that. I would say I don't know if this kind of answers it directly, but there is a one moment that comes to my head. And it really was in my intern year, which is usually the first year that you do after medical school. So it's kind of your first year as a doctor where for radiology, you're just doing general medicine. So you're not doing any radiology yet. You haven't really learned any radiology yet. And you're just doing kind of a general medicine doctor. And this is kind of my first year out from training, where I'm still really learning the basics of medicine. And at that point in my life, I was still on the fence of doing radiology because we're not really exposed to it much in medical school. But I was just drawn to kind of the kind of procedural aspect of radiology and the diagnostic aspect of radiology. But I wasn't really I didn't really practice it yet to really know that's what I wanted to do for the rest of my life. But just kind of talking to other doctors, that's kind of what I decided to pursue. But again, my heart kind of wasn't in it at the time. But I was taking care of someone in the ICU who was, we weren't really sure what was going on, but she was having a lot of abdominal pain, and ended up getting a CAT scan. And I was taking a look at the CAT scan. This was kind of overnight around 3 a.m. I was taking a look at the CAT scan, and I saw some active bleeding inside the belly. And, in the middle of the night, the kind of CAT scan results aren't readily available. So I looked at it myself, and I talked to the other doctors in the ICU taking care of this patient. I said, I think she's having some internal bleeding. Instead of something else going on. I think they were concerned there was an infection going on. There was inflammation with colon, some GI issues. It was a little unclear. But the CAT scan really made it clear. And that's kind of when I really realized the kind of how helpful the imaging was. Instead of kind of doing the guesswork, the CAT scan really showed, there's bleed here inside the abdomen. This is what's going on. And, and this is kind of what we're going to do about it. And I kind of helped expedite that process instead of waiting, hours for that CAT scan result to come back. So once I kind of talked about it with our team, they were all in agreement quickly and were able to give blood transfusions and really prevent any kind of major complications, compared to if we were to just leave it alone and wait a couple of hours to diagnose it, where she just lost too much blood, and could have kind of ended up much worse. That's when I was really kind of felt it in my heart that I'm like, this is what I want to do. I want to do radiology. This is kind of the kind of impact that imaging can have on patient care. And this was just even the diagnostic aspect without the procedures. And you add another layer of procedures onto that. So that was kind of, one night where we're working 24-hour shifts, and this was probably got done around 6, 7 a.m. And I was just so exhilarated and so excited and happy that I was able to kind of take care of that patient and make the right decisions in a swift way. And that's kind of when I knew that, radiology is for me.
I love that you really lit up in saying that last part. It definitely had an impact on you and still continues to have an impact on you as you recall that very defining moment in your career. And it must have been even, better when you realized that you not only could read it, but then you could do something about it. And that's where the interventional radiology came in, right?
Right.
It's like, you know what? I don't have to depend on anyone else. I not only can read it, but then I can do something about it. I don't
Exactly.
have to wait for some other doctor to come in here in the overnight hours to be here. I can actually take care of this. So
Yeah.
fantastic. Well, we do. I'm opening up to questions. So I know we have quite a few people in the live studio audience. So make sure to raise your hand, get your questions in the chat so we can get to them. I know, let's start with Douglas first. Douglas, do you have a question for Dr. Mendoza?
Yes, sir. Thank you for joining us and welcome to the team. It's cool to have you with us.
Sure, my pleasure.
For PAD patients, can you remind us again the importance of having our hearts checked? and making sure we're aware of that also, because one go hand in hand with the other one. And then a little short one would be, how are you worried? Are you worried about your long-term effects with the radiology?
Yeah, can we ask those separate? Ask the first one.
Okay.
Let's let him answer. And then if each person can just, if you have two separate questions, just ask one, and then I'll let you follow up with another question. But go ahead and answer the first one about the importance. What is the importance of getting your heart checked if you have peripheral artery disease?
Sure, I would say that's very important. Anyone who comes into our office with either suspected or known peripheral arterial disease, if you think about it, the process affects the whole body. So the plaque buildup occurs throughout the entire body. There's three main areas that those kind of plaque buildups, common areas that plaque buildup can occur and really cause a lot of issues. And number one is the heart. Number two is the neck or the carotid arteries, which can lead to a stroke. And then number three is the legs, which can lead to a lot of leg discomfort. So if you have significant plaque buildup in any of those areas, there's about a 30% chance or higher you have it in another area. So if someone comes to us with a new diagnosis of peripheral arterial disease, I always make sure to get an ultrasound to take a look at the arteries of the neck to prevent any stroke, as well as send them to a cardiologist if they don't have one already, to get their hearts checked, even if they don't have any problems, to get their hearts checked. And some of them especially do have some kind of ongoing chest pains that they've been ignoring, and kind of even more important in that subset. But even for patients who don't have any chest pains or difficulty breathing or any discomfort, definitely kind of a checkup to take a look at the arteries of the heart is something that's important if you're having plaque buildup somewhere else.
Fantastic. Now, Douglas, question 2.
We've heard this a couple of times. How worried are you with being a radiologist about the long-term effects that will have on you and what you go through?
Oops, it might be that there you go. I think we have you back.
Do you mean from the radiation aspect or from something else?
Right. There was a movie that we have talked about here. It's called Scattered, and it's about the radiation exposure for doctors. And we find that there are some doctors that say that it's not worth risking their life to save the limb of someone else. If they can't get it done in 90 minutes or less, it's not worth it for them to do it at all. And I know that's tough to hear, but we've actually had people say that.
Yeah.
And when you were talking about 4 hours, 4 to 5 hours, as if it was nothing. Oh yeah, I did this case. Yeah, in about 4 to 5 hours. Yeah, we were able to get through and do it all in one shot. But here doctors are telling us, oh no, if we're not literally in and out in 90 minutes or less, can't be done. We're sending them to surgery, either for bypass, endarterectomy, or amputation.
Yeah. So, there's been studies, long-term studies on radiologists, and there were kind of no kind of increased rates of known cancer specifically from the radiation itself. So that was something I was concerned about. But after talking with a couple of radiologists and looking at some studies, as long as when we do these procedures, we are wearing kind of a full lead outfit, which protects us about 99% from the radiation. So even though we are using radiation, kind of the main areas from the neck all the way down to our knees is covered in effects. Now, even though we get kind of minimal radiation, if we do multiple procedures a day, every day of the week, every week of the year, even though those small doses from a patient standpoint, they can kind of add up to someone who's doing it all the time, taking care of multiple patients. But our radiation doses are monitored. And as long as we are under the kind of annual limit, it usually doesn't have any long-term health effects. So that's kind of, we are taught in sort of radiation safety, to kind of how to minimize the radiation to both us and the patient, with proper shielding, proper technique, and proper equipment, to really minimize those effects to zero. Now, if you're not doing those, then definitely that can increase your risks for long-term cancer over a decade or two. But in the short term, I would say that's not really a concern.
Now, Douglas, you realize you're asking the right person here, an interventional radiologist, because it's the only practice that actually has an advanced certification that is required for radiation safety.
Mm.
Right, doctor?
Yeah,
you had
that's
to go
correct.
through radiation safety. You had to get a certification for that.
Yeah. It's part of our board certification as well. So I would say compared to other specialties, radiology, we are really taught kind of specifically about the radiation, the effects of radiation, how the X-ray machines work, how the CAT scan machines work, how the MRI machines work, and why they do what they do, and kind of how to prevent the radiation aspects, as opposed to other specialties who are kind of maybe taught the main bullet points on that, but aren't really kind of drowned in the details like we are.
I was in a test.
They don't get their doctorate. They don't get it until they can actually
Yeah.
pass that aspect, which is great. We do have a question that's coming in from Marcia. Marcia, go ahead and ask your question of Dr. Mendoza. Marcia, go ahead and unmute. She might have fallen. There she is.
Oh, yeah. Thank you, Dr. Mendoza, for pitch hitting it, especially at the last minute.
Sure.
I wanted to ask something that I asked I don't have an interventional radiologist. I have an interventional cardiologist. But sometimes my arms and my fingers kind of tingle. And of course, I have PAD. Nobody really talks about it in the arms. But yet, when I first learned about it, it said peripheral, it could be in the arms or the leg. So I'm curious if you see that in the arms or hands much, or is that a different type of vascular disease like Berger's or something?
So it can happen in the arms. It's just much, much, much less common too. I would say, again, I think when I spoke earlier about it happening in the legs, the heart, and the neck, those are really the most common places, but it can happen anywhere in the body. So we do see it in the arms, and we can treat it in the arms. It is a little more challenging in a sense, since you are more, you have more use of your arms. You're using your hands more. You're using your arms more. So it's less frequent to see it in the arms, but we do. And I would say there's certain vascular diseases, like you said, Berger's, Raynaud's, things like that, where it's not kind of the same in the legs in a sense, but it's similar, but there's some differences just because we're a little more sensitive in our hands. We use our hands every day. We have a lot more sensitivity in our hands. So a procedure that we do in the leg is that kind of seems no big deal. It's kind of a smaller, kind of a bigger deal in the arm, more so because there's more movement of the arm. You're kind of bending your arm more. So we try not to place stents across the joints in the arm and things like that. As opposed to the legs, it's pretty well safe and documented, but sometimes in the arms it can be a problem. And as well as kind of, often after procedures with the PAD in the leg can swell, which is normal and expected. But if you have any
I can't hear you.
Yeah, we're losing you just a little bit there, doctor.
What's that?
Oh, we lost you for a second.
Oh, sorry. I was saying that we do treat patients with the arms, but I would say we're a little more picky to really make sure that the arteries are the main problem. At least the larger arteries are the main problems, and it's not something else going on. Because what we call small vessel disease, which is problems with the arteries in the hand itself, those can often be treated with medications and not necessarily a procedure.
Thank you very much.
Yeah, we have had a few people actually, when people say it's rare, and then we get quite a few cases actually in our groups, of them, but they still are the few and very, very far between because, most doctors rarely even have patients come see them with it. But it is important for people to know that if they do have the symptoms in their hands, to always make sure to ask their doctor about it and make sure to get and make sure to get an ultrasound and or a CT scan to determine if there is something vascular going on your arms that can be treated either with medication, therapy, or some sort of intervention may be needed. We do have a question coming in from Nancy. Nancy, go ahead and unmute and ask Dr. Mendoza your question.
Okay, Dr. Mendoza, over 9 years ago, I had a widowmaker and I had a heart attack afterwards. And thank God I had an EMT that was there that saved my life. And I used to get stress tests every year. So kind of going back to the stress test thing, I'm a little concerned because now my cardiologist, he's electrophysiologist, is saying that it's too dangerous to give stress tests every year because of, it could cause cancer. So unless you have symptoms of like chest pain, but women have different, they get different symptoms. So I'm a little concerned. What is there anything else that I can do? Should I get my heart checked periodically? I don't know. And I'm fighting PAD and a lot of different things. So just wondering what your thoughts are on that.
Sure. I can't comment specifically on the current guidelines since we kind of do our work mainly away from the heart, since usually the heart issues are taken care of by the cardiologist. But generally speaking, the main problem or the main kind of the best benefit would really be to kind of do routine exercise or stay active, really to keep the heart in shape, especially if you have known blockages of the arteries in the heart there. Now, in terms of definitely if you're symptomatic, it's no question, but to kind of routinely get a stress test kind of annually, I don't know if that's really kind of necessary. It really depends on a number of factors, which I guess it's really hard to comment on specifically for you. But that's something the cardiologist would probably know better more. But I would say if you are worried about, if you're not having any symptoms and you are worried about your heart, especially if you are able to exercise and stay active where you put more stress on your heart and you're not having problems, then that relatively means that your heart is in good shape. If your heart is able to take on that additional stress, and again, kind of staying active and doing exercise will improve your cardiovascular health, not just your heart, but throughout your whole body.
And make sure, you double check on your symptoms. That we had a cardiologist come on, Dr. Parag Doshi, who said the new angina is fatigue. So especially women, please pay close attention to that. You also had a question about Lp(a).
Yes. And basically I'm just volunteered to go into a clinical trial with Eli Lilly, because I had very high lipoprotein A. It's at 237 and they're saying it should be at 77. And, I'm fighting hard, everything I do. I mean, I walk an hour a day, I eat healthy, I'm doing all kinds of things. I do have a later too. And, I do a lot of exercise, but, I'm worried now this lipoprotein A, there is no medication for it. And so this clinical trial is going to be to try to find if this medication Eli Lilly has is going to, going to work. So anyway, do you know much about it? I guess I'm trying to do research on it. I'm not hearing much.
Yeah, to be honest, I don't know much about it. I mean, we kind of learned about it, but in terms of kind of treating it and managing it, I have no experience with that.
Okay. Well, I thought I'd ask anyway. Thank you.
We're just hearing a lot about it across social media. And I think we're just going to blame it on Nancy. The moment she messaged me, the powers that be called the bots in Facebook saw that she and I were talking about it in a private message. And suddenly I'm getting all the advertisements for all of these research opportunities. across social media every single day. So Big Brother is always watching.
Yeah.
So it's all Nancy's fault that I'm getting.
Oh,
I'm just kidding, Nancy. You're fantastic. Okay, so I believe, well, we're just gonna say Tiger had a question. If she's still here, I don't see her though. She had a question. If she's still here, go ahead and ask, but I don't see her. So I had another question come in from Cindy, and Cindy is asking, she said she has to go on a very long road trip. She's the driver. What are some recommendations for driving with PAD for extended periods like 6 hours?
I would say the main important thing for PAD, which is specifically for arterial disease, I would say that should be fine. If your legs start to feel uncomfortable, it's always important to kind of take a break, stretch, either get out of the car and pull over, or kind of do some leg exercises in the car if you can't pull over. But I would say more so specifically for chronic venous disease or vein problems where you have swelling in the legs, or a known blood clot or whatnot. It's even more so important, I would say, in that population, to really kind of get out and either move around, stretch, and if you know you're going on long car rides, to wear a compression sock as well. But I would say frequent breaks is what's recommended, just to kind of keep the circulation moving. If once the circulation becomes stagnant, that's often when symptoms start to come on, and cause some discomfort.
So with compression socks, they can be contraindicated in the highest levels. So for those with PAD, do you have a certain level you should talk to your doctor about to see if they're okay for you?
Yeah, usually for, when we kind of talk about PAD, it's just kind of plaque buildup in the arteries. Everyone kind of start after the age of 50, after the age of 60. Everyone gets some mild plaque buildup in the arteries. So mild plaque buildup is just very common. It's fine to wear compression socks for those subset population. Usually, I leave it up to the patient. If they feel good and they like wearing compression socks, then I would recommend continue wearing them. Some people hate them, even though we recommend them. Some people hate them and can't tolerate them. And we just kind of deal with it from that instead of kind of forcing them to wear them. Now, for people with known blockages in the arteries or severe plaque buildup, where we know that the blood flow is compromised to the point where it's causing severe pain or wounds and things like that, that is where compression socks should not be worn. And you would know if you tried to wear them on, your legs will be more painful and more uncomfortable, and you would not be able to tolerate them. But if someone told you you've had PAD, but kind of no serious blockages, no kind of serious symptoms, and you wear the compression socks and you like them and they're not causing any problems, then I think it's fine to continue to wear them.
Fantastic. Okay, Janet, go ahead and unmute and ask your question of Dr. Mendoza.
Thank you. I was about to have my angioplasty, and they did a scan on my right groin, from my groin down, got 2 inches down, and they stopped, had a meeting amongst them, and then they rang the surgeon and they cancelled my, the procedure, and I was sent home. And I saw the doctor just the other day, and I asked him why, they did that. And he showed me the MRI. I'd seen it before, where there was 2 blockages, well, narrowing, 2 spots. But then the next one he showed me was a scan just prior to the op, and you could see where the blood had stopped. But he said to me, well, nothing much we can do except for a bypass, and they can't find a vein because my left leg hasn't got it, and it's found its own blood things tracks to go down to my bottom of my leg. And so he said, we'll just wait for 6 months and you can come back in again. We'll get you back in. But meantime, if it gets worse, go to your GP and we'll get you in and try and do the op. What my question is, why can't they open up their blockage now? You know?
That's a little hard to answer because I'm not exactly sure where and how long or how severe the blockage is, just based off your description. But I would say usually when we are dealing with blockages in the arteries, traditionally surgery was always the kind of main option. And so a lot of our procedures in interventional radiology, even dealing with procedures outside of vascular disease, they're always being compared to the surgery standard because that's just how things were kind of always done before. And so we don't compare them to nothing. We always compare them to surgery. So the main question often in our field by a lot of the vascular doctors is which one is going to be better for the patient? Angiogram, which is a minimally invasive procedure that I think mainly what we've been talking about here, or surgery, which is kind of a surgical bypass, which is a little more invasive. And I would say that there's certain studies say one's better than the other, and other studies say that that's not true. So it's still a little unclear, and it's hard to really kind of say that our specialty, kind of the things we're doing, have only been in the last 20 to 30 years, whereas surgery's been there since the beginning of medicine. So it's really hard to kind of say one thing is 100% better than the other at this point. So depending on kind of what the surgeon is comfortable with and how they were trained, if they were trained to just do open surgery, or if they were trained to do both, or one or the other. I don't know specifically what they are able to do, but if they were not kind of trained in doing an angiogram and they were trained in doing kind of more so open surgery, then that could be one of the reasons. Or depending on how bad the blockages are, sometimes the surgery is a better option, where the bypass stays open much longer compared to some of the stents that we place. But again, it's very different depending on where the blockages are and how severe they are. And sometimes people are too sick where they can't undergo the surgery. And that's when kind of we're able to take those patients on because it's much less invasive and much less anesthesia risks.
And I think you bring up a really good point, doctor, that doctors will offer you a lot of times what they are most comfortable with and what they are trained in. And if that doctor is your only option, you want to go with what they're most comfortable with, as long as you're comfortable with it as well. But Janet, where are you located? It sounds like you're in Europe with a GP.
New Zealand.
You're in New Zealand. Oh, you have two
Wow.
of the most advanced doctors that we know of. You will have to message me because we know of, there are quite a few. You have some advanced doctors there in New
I
Zealand.
looked him up yesterday. I Googled him yesterday.
Oh, the one that I suggested to you, was that
Yes.
you?
Yes.
Ah, oh, good. Is he near you?
He's in Auckland, and that's actually where I went for my procedure, was in the Auckland hospital. But I'd never heard of him, so I'll look into it deeper.
Yeah, and you know what, that particular, and everyone's wondering who this is. I'm not going to tell anyone who this is, because he won an award for Global PAD Interventional Radiologist of the Year. He's been doing this forever, and he's on the cutting edge, and he's really having an impact not only in New Zealand, but globally in terms of what he's doing. So now I am making everyone wonder even more. If you were on the interview earlier today with Dr. Lorenzo Petrona, you might have actually heard the name. I know. So you'll wait for that. But yes, you know exactly. But you see, actually, I think you're the only one who knows, because that name is the one I did send you. But it's definitely worth, checking on. A lot of the doctors, especially in outside of the US, they do have, their committees, and they have conversations, right, about the patients and determine what might be best. And in many cases, they do decide that surgical is better. But where things I think are moving, globally, is to always really looking at, if you are going to have a procedure performed, what is the contingency plan when that fails? And I make everybody think about it. So you're going to have a procedure. What is the contingency plan when that fails? And I think, Dr. Mendoza, you would agree, it's not a matter of if these are going to fail, whatever the procedure, it's a matter of when. And so, if, for example, and I know Douglas here doesn't mind me sharing, but if a doctor is going to go after an axillary bifemoral bypass, as Dr. Petrone said in our previous interview today, for people in Europe, I mean, the doctors really take that procedure seriously and say, am I going to just be able to give this patient more time to get their, affairs in order before they die? It's also used, in case of an aortic infection where they need to buy the doctor's time to let the antibiotics work, but they can always go back in at that point and revascularize the aorta once and bypass that bypass when the time is right. But for the most part, like that particular bypass, there are very few options, if at all, after that. So really make sure, a big question you need to be asking your doctor with any procedure: what is the contingency plan when it fails? Which is why we always say conservative is better first. Walk as much as you can, as long as you can. Do the conservative therapy for as long as you can tolerate it, because most patients, surprisingly, do very, very well with that over the course of time and never even need a procedure. So I don't know, Dr. Mendoza, if you agree or disagree with any part of my monologue there, but I get on my soapbox and it just keeps going.
Yeah, no, yeah, I would say kind of what you said is often what I tell patients as well. Really, kind of walking and exercise is the single best thing you can do above all else that will improve the blood flow in your legs. And when that fails, then we start doing procedures. But once we start mucking around in there, it becomes an ongoing cycle. And whether that's lasts for 3 months or 3 years, it's different for everybody. But again, like you said, it is going to come back at some point. And it's just kind of the nature of the problem.
Is that helpful, Janet?
Thank you very much. Yes.
And we have an interesting question coming in from Rose. She developed polymyalgia rheumatica in June of 2023. She was treated with steroids, and then not long later, she started developing symptoms of claudication in her legs and diagnosed with PAD. The vascular surgeons didn't seem to really understand the diagnosis, she says. And she says she's been taking all of the steroids faithfully. She's walking all the time. And she's wondering if her arteries are inflamed, but not blocked. Could they ever be clear if the inflammation eventually goes away? And I think the direction probably we take this is just simply the fact that if you're not blocked and you're not having lifestyle limiting symptoms or symptoms that would indicate that you have critical ischemia or acute ischemia, where you have rest pain that wakes you up at night and a wound that won't heal, just keep it on, right?
Yeah, I mean, I would say it's hard. I mean, an ultrasound, I think, would probably answer that question. If the ultrasound shows that the arteries are open and there's no kind of severe narrowing or blockage, then I would say I would probably attribute it to the polymyalgia rheumatica. But again, it's very different. I mean, claudication specifically should be reproducible. Kind of leg pain after certain distance, and you need to stop and rest before you can go again, and kind of repeat it every single time. Whereas kind of, if it was more of an inflammatory arthritis, that acts a little differently. So if it's just pain, general kind of leg pain that you may be thinking of claudication, that's something to consider as well. But specifically for claudication, an ultrasound, if the ultrasound shows some mild plaque buildup, that's not a problem. But the ultrasound would really answer that question for you, to see if you have blockages or not. So if there's no blockages there, I wouldn't think that the claudication is from a circulation problem. But again, if you are able to kind of walk without problems, and the steroids are helping, there's not much more we can do if you're not being limited by your problems.
Great. And we have one more question right here from Douglas. Then I have one more that actually just came in. And if no one else has any questions, I think we'll end there. But first, Douglas, go ahead.
Yeah, what Kim was saying is, how do you feel about your patients becoming the best advocates for themselves they can be, and the importance of getting a second opinion sometimes and becoming educated, which is what Kim's doing for us, because you're here teaching us, helping us learn as patients to be our best advocates.
Mm-hmm. Yeah, I mean, definitely the more, I try and teach the patients as well, because once you kind of understand what's going on, it really is more simple to follow rather than just being told that you have a blockage and we need to fix it. But really, the main issue, especially when we see kind of a lot of plaque buildup from PAD, it's from kind of the main four culprits that I say. It's either smoking, high blood pressure, high cholesterol, diabetes. And if those are often uncontrolled, it leads to kind of faster progression of that plaque buildup. So we can kind of do these procedures, but oftentimes we definitely have patients that take great care of themselves and make a lot of changes that they need to, and definitely have the opposite, where patients still continue to smoke. They don't want to exercise. Their diabetes is out of control, and they're not really taking great care of themselves. And so really kind of understanding that it really is a lot of things going on leading to this plaque buildup, that we can take care of the arteries, but you need to take care of everything else, to really get great outcomes and really kind of make they are really pretty big life changes, but they're always kind of for the better of your health.
Fantastic. I just want to double check we have a few in our live studio audience that I'm not sure. I want to make sure that if they do have any questions, we have Kim here, we have Amanda, that I just want to make sure if you have any questions for Dr. Mendoza before I just wrap up. Kim had a question, which we asked Dr. Petroni, but I'm curious your thoughts. How low is too low when it comes to LDLs? Can your cholesterol with your LDLs ever be considered too low? What is your perspective on that?
That I don't know the right answer to that, to be honest. I would say that that's not something that I routinely kind of monitor kind of
That's
actively.
probably not something you see very often either.
Yeah. I would say that's something that I usually have patients kind of talk with their primary care doctor about. But definitely in terms of being on statins is definitely part of the mainstay treatment of dealing with PAD.
So my final question is from someone that just came in on the Facebook page is what are some of the most incredible advancements in PAD treatment that you are most excited about today?
I would say there's a couple of things. I would say that one of the main challenges that we see is treating what we call below knee disease, where is the arteries kind of from the knee into the calf and foot are blocked. And there's really not great treatment options for that. We are able to kind of open up these blockages with a balloon, but we don't kind of routinely place stents below the knee just because those arteries are small. They're about 2 to 3 millimeters big, even 1 to 2 millimeters down into the foot itself. And so no stent, we really don't have the stents available to really get good long-term outcomes there. And so kind of the current advancements right now are finding stents that we are able to place below the knee to kind of keep those arteries open. And as well, something called deep venous arterialization, or DVAs, is something that we perform that is kind of a last-ditch effort where we connect an artery to the vein to get some oxygenated blood into the foot, since the normal pathways are blocked. So really kind of continuing to kind of research into those two main kind of fields, I think will lead to a lot of advancements into kind of managing those patients.
Okay. And Amanda does have a question. Amanda, go ahead and unmute and ask Dr. Mendoza your question. It might take her a second just to go ahead and unmute. Maybe not, maybe not. Maybe she's typing it in there. There she
Maybe.
is. Hi, Amanda.
Hi. I know that you had said about the stents. You guys were talking about stents, and I was told that with my diabetes, and they're afraid to use stents on me. I have already had 2 endarterectomies and a femoral bypass. And so I'm kind of scared now because it's the if or when type thing, when it's going to fail. So that kind of scares me because he already told me that with my left leg, because it's in both legs, in my left leg, he said that I don't really have a vein that is good to use to even do another bypass if I did need one. So I'm not sure. I guess I just kind of wanted to make that. I don't know. I'm kind of scared. So there's that.
I guess, do you mean stent? Did they talk about where the stents would be? Kind of in the
iliac, in the
okay.
iliac.
Yeah.
Why
that's
would you
where
be
they were
scared in
thinking.
the iliac to put stents in the iliac? Isn't that standard to put stents in the iliac? They're pretty durable, the ones that we have today.
Yeah. Yeah, I would say the patency rates in the iliacs are very good compared, kind of the lower down in the leg you get, kind of the worse off the patency rates are. But I mean, the diabetes alone isn't something I take into consideration when placing a stent. It really depends on how the blockage looks like, how long it is, and where it is. That helps me decide if it needs a stent or not. The diabetes alone, I'm assuming when we talk about kind of vascular disease from diabetes, it's often dealing with the arteries below the knee. I mean, it does affect the arteries in the thigh and the belly as well, but more commonly, it's dealing with the arteries from the knee down, which I could understand in that sense, not kind of being able to place a stent like I just discussed, but I'm not sure specifically why you were told you couldn't be stented in the iliacs. That's something that we commonly do.
See, and the thing of it is I had a blockage in the femoral right at the spill off on both legs, and then a blockage in the iliac as well. So I'm not sure if when he did the bypass, if he just kind of included that area too. I don't know.
Or sometimes if they're doing the bypass, it's kind of already kind of bypassing that iliac blockage where he doesn't need to place a stent, maybe, if that's what he's referring to, where the kind of opening up the iliac isn't necessary because you have a femoral to femoral bypass. But again, I'm not sure. It really depends on the imaging where the blockages are.
Okay.
Yeah. Amanda, go ahead and stay on after we're done here. I want to find out a little bit more information, but
Okay.
you know, doctor, there are so many new tools, new techniques, so much, you know, on the way that we're all so excited about. It should, I would hope, give patients hope for the future of PAD, especially seeing young guns like you know, already learning the advance in performing the most advanced limb salvage techniques and exhausting all efforts, and your passion for exhausting all efforts to save people's limbs. So, you know, in the last few moments here, any final words of encouragement for patients out there with PAD?
I would say, a PAD is unfortunately a lifelong problem. And it's something that you're always going to be dealing with. And if it's something that I think should be taken seriously, because it could really, if it's left unchecked, it can really lead to some really very poor outcomes, and really very poor quality of life and pain and discomfort. So if we can avoid that, that's really our main goal. But a lot of it is doing things on your own. Those are kind of changes you need to make. We can do these procedures to open up the arteries, but to keep them open is really dependent on the patient, and really kind of doing your part in a sense, where kind of again exercise, making the kind of lifestyle changes, which is always easier said than done. But to kind of quit smoking, to get the blood sugars under control, the blood pressure, the cholesterol under control, all of those things will really kind of overall not just benefit the PAD in your legs, but just your overall health. So there's really no downsides to kind of working on that. But again, it's always easier said than done. If it kind of asking people to do anything new is always going to be a challenge. But I recommend you kind of get motivated to kind of make new changes and stick to those new changes. And it'll really lead to a better life that I think most people are hoping for.
And Doctor, I assume you have Facebook, so we are officially inviting you to join our private Facebook group, as quite a few other doctors have joined, and in their spare time, as if you have that much spare time, but they do jump in and chime in and answer some of the questions in the group when they have a moment, or if we can tag them, padsupportgroup.com or .org,
Okay.
either one, and we'll make sure to add you. And we don't use it as an opportunity to give medical advice. We try to empower people with the critical questions to ask their doctor, so that they can get the care they need wherever they might
Correct.
be. So
Yeah.
thank you so much, Doctor. We really appreciate you. Hopefully we'll see more of you in the future, and especially in our social media network. But thank you everyone for joining us on this What's Up Doc edition with Dr. Edel Mendoza with American Endovascular. We never even found out, are you in New York or are you in Orange with Dr. Runback and Dr. Herman?
Yeah, I'm in West Orange with Dr. Ronback and Dr. Herman.
So we actually had a couple of those patients actually here, that were a part of that crew over there with Dr. Herman and Dr. Runback, as well. So they'll be giving them feedback, on you.
Good
And we
things,
think
I
you're
hope.
great. So we do hope you come back. But again, everyone remember the advice and views offered are that of Dr. Mendoza, as well as myself, as well as the patients that did participate in this particular series. Do not act on any information or any advice that was offered here without the explicit consent of your own healthcare team. Okay, this is for educational and informational purposes, designed to just empower you to go to your doctor and have a more informed conversation. Have a great week, everybody.